Good afternoon, everybody. My name is Maureen Nash. I am a geriatric psychiatrist and an internal medicine physician, and I'm talking today about the importance of sleep and sleep disturbances in older adults. I have no financial disclosures. I'm not planning on talking about medications, but I will disclose anything regarding them at the time. This is accredited for one Category 1 AMA credit. So today we're going to be talking about sleep. Why do we need it? Why do we want it anyway? I'm going to talk a little bit about sleep and myths related to older adults as part of just a general campaign to get accurate information out there about older adults. I'm going to talk about the etiology of sleep problems, and I'm going to address some ways to help with sleep that may be different from what you have been doing in the past. So, everybody sleeps. There actually is a very rare genetic disease that prevents people from being able to sleep. First, it limits it, and then ultimately it prevents it entirely, and that is a fatal disease. Sleep is essential. So why do we sleep? Well, it's actually one of the times when our brain is working the absolute hardest. Our brain forms new pathways. It processes information from the body and the mind. That's when we consolidate memory and learning. It's very important for our ability to attend or pay attention. One of the best ways to cause someone to have poor attention is to interfere with their sleep, as it were. And one of the best ways to help promote good attention is to protect sleep. I mean, it's extremely important to have adequate sleep to improve cognitive performance. And sleep itself has a specific architecture. So there's stage 1, where you are kind of half awake and half asleep. Stage 2, 3, 4. Stage 4 is where you are sound asleep, and it's actually very, very difficult to wake anybody while they're in stage 4 sleep. And then there's REM, where we dream, and then there's and then that repeats in cycles throughout the night. And that's sort of the general overall structure of normal sleep. So what happens when we have sort of chronic mild sleep deprivation? So not some sort of torture campaign on a daily basis, but something that's much milder, but seems to happen, more days than not in a typical week. Well, what we find is that people have significant difficulty keeping their emotional responses the way they would normally. And it puts people also at risk of anxiety disorders and major depressive disorder. There's a decreased pain tolerance in people who have chronic sleep deprivation. There's an increase in diabetes and other metabolic diseases in people who don't sleep well. There's impacts on your immune system and the risk for infectious diseases and other things that our immune system protects us from. And then your resting heart rate doesn't trough appropriately. I love that. It's like a total medical phrase. How could you make something more complex than it possibly needs to be? But so your resting heart rate, which is the lowest that your heart rate gets, that occurs during the night or during the time when a person is sleeping. And it occurs sort of after 6 hours. And if you sleep for up to 8 or 9 hours, the trough, the lowest recording would be around the 8-hour mark. And so that's the resting heart rate. And that kind of, it gives your heart a break as well. It is a marker for your sympathetic nervous system. So there are a number of disease states where your resting heart rate is abnormal and doesn't go sort of low enough to give your body a chance to recover, such as post-traumatic stress disorder, a number of endocrine diseases where you have cortisol abnormalities, heart disease. So there's many things that can affect that, including mild chronic sleep deprivation. So I'm just going to talk a little bit about about older adults and some of the sleep myths. When I used to work on an inpatient geriatric unit, it was amazing to me that no matter how much people were sleeping, and we did have nurses and nurses' aides who were checking on people every 15 minutes, 24/7. So we knew that people were sleeping, but every older adult on that unit complained of poor sleep. Despite most of them having some sleep. There's actually another group where you find this same kind of complaint, which would be people who are on call. People who are on call often complain that every time they are awoken with by their pager, that it takes them hours and hours or a long time to get back to sleep, and they cannot fall back to sleep easily. So it does turn out that there are changes in our sleep architecture as we age. But interestingly, the people who complain about their sleep are only those who are unhealthy. So the fact that somebody is talking about their sleep, the fact that an older adult is very focused on their sleep, doesn't mean that their sleep is necessarily objectively different than other people of the same age group. Although the more ill you are, the more medically complicated you are, the worse your sleep. But basically, it isn't that different from healthy older adults. But what is different is who is focusing on it and who is noticing it, and it's really those who are unhealthy. There's also this kind of myth out there that all older adults sleep poorly, and their sleep just progressively gets worse over time. And again, that there are times when that is true, but not actually related to age. There are lots of different ways of looking at sleep. There's sleep efficiency, which is, ability to get to sleep and stay asleep. There is sleep sleep latency, how long it takes you to get to sleep. There is, many different ways of cutting sleep up and looking at it. But for older adults, really, there are very, very few changes. And what changes there are very slow for those who have good health. So it actually, I think we in healthcare, either psychiatric, behavioral healthcare, or other areas of healthcare, I think we're at a little bit of a disadvantage because we spend our days generally with people who are ill, and they do have some sleep problems, and they do complain of those sleep problems, but that actually isn't true for all older adults. So I just think in our efforts to reframe and get a more accurate picture of older adults, I think that's important to know. So aging does not cause poor sleep. And I see I was not very clear in that first line of the of the slide, so I might change that in the set that is available to people afterwards. Most diseases, most illnesses are associated with nighttime and daytime sleep-related complications, most chronic diseases. And the biggest impactors were major depressive episodes, which you see in major depressive disorder, you see that in bipolar disorder, and you can see that in some people with schizoaffective disorder. And then the next biggest area were people who had significant osteoarthritis or chronic pain. And there is no gender difference. So it isn't that one gender sleeps worse than another. So what it really is a function of how medically ill you are, and pain and depressive diseases are the ones that have the biggest impact on causing poor sleep. So, and I just think it's key for us to know that both acute and chronic diseases increase in frequency with age. And it's really the disease process that is related to the poor sleep. And we also do lots of things to people who have disease. You know, we might operate on them, or they may require a hospitalization or bed rest in a nursing facility or a hospital. We give them medications, and medications often interact with each other in ways that are complex and hard to predict. And so there's lots of reasons why those people who have acute and chronic diseases are not sleeping well. So, and one of the reasons to know about why people might not be sleeping well is that you should target your treatment toward the underlying diseases rather than focusing on sleep. And the group of people that this is most important for is older adults. Older adults routinely, older adults who are ill and not sleeping well are quite likely to ask for help with a sleep medicine. And even more so, older adults who live in a facility, their caregivers might be asking for sleep medicines in order to sedate them. And I would just like to advocate that that not be the first step on our list. I think the first step is to really look at what is different. So there are age-related changes. So there is a change in that as we get older, people, night owls, the proverbial night owl really turns into a morning lark. Older adults tend to go to bed earlier, but that also means they're going to wake up earlier. And so that there's a shift in when people are sleeping. And of course, there are some certain groups where this is just very different for them altogether. So for instance, people who for decades work a night shift, their sleep cycle may be very different when they get older, and it's going to be impossible or very difficult to successfully change their sleep cycle back to what might work best for caregivers. And so you actually need to care plan around that if people did work a night shift. It's one of the most important questions to ask when somebody moves into a facility is, when did this person sleep, during most of their years of their life. And then comorbid medical and psychiatric diseases. I cannot overestimate the importance of making sure that these diseases are treated well. Pain, post-traumatic stress disorder, major depressive disorder, etc. And rather than targeting sleep per se, I would like to advocate that we actually target the underlying medical and psychiatric diseases that people are experiencing. And in particular, with major depressive disorder, what we see is there's changes with REM sleep. and with the REM cycle as people sleep, for people with post-traumatic stress disorder, they have trouble with what we call heart rate variability, and they also have trouble with stage 3 and 4 sleep, which is when sort of nighttime abnormalities occur, such as flashbacks that people might have. They might call them or refer to them as nightmares, but they're actually not occurring during REM sleep, the kind of flashback / nightmare that people with PTSD have. Primary sleep disorders. And when would you want to be alert for that? Well, people who are overweight or obese are at very high risk of sleep apnea, obstructive sleep apnea. People people who are on serotonergic medications are at very high risk of restless leg syndrome, RLS, as well. It can occur just all by itself. Restless leg syndrome is really related to a shortage of dopamine, and one of the things that can decrease dopamine levels is serotonin. And so I think there's been a very large increase in the use of SSRIs, or selective serotonin reuptake inhibitors, which are used for depression and anxiety. And as the use of those medications has increased, so has the incidence of restless legs. And so rather than adding in a second medicine for restless legs, what you might do is see if there is an alternative or a decrease that could be done for some of the serotonergic medications that people are on. So if you have a sense that somebody might be having a primary sleep disorder, what you're going to want to do is refer them for a sleep study. We also can see primary sleep disorders in anybody who has cardiac disease or respiratory disease, as well as people who have neurological illness. So really the threshold for referring somebody who has multiple medical or psychiatric conditions to a sleep lab for a full assessment of their sleeping challenges should be relatively low, because sort of the study of sleep is an evolving science, and pulmonologists who specialize in sleep often have interventions that they can do with people that will actually address the underlying problem of the poor sleep. I know in residency, one of the most profound cases I had in my primary care clinic was a gentleman at the VA who had become overweight and started to develop sexual problems, which was impacting his marriage. And he had hypertension. And so I was, sort of going through a checklist, and I said to him, I am wondering if you are having a sleep disorder, if you're having sleep apnea, and referred him to a sleep lab. He got a CPAP, and he was willing to use it and used it correctly. And within 6 months, he had lost significant weight. His sex life was better. His blood pressure normalized. He was able to go off of blood pressure medicines. I mean, it was an entire turnaround. Now, that was a younger person rather than an older person, but I think it really is just a testament to the importance of treating a primary sleep disorder. And then poor sleep habits or sleep hygiene, what we call sleep hygiene. So there are learned behaviors and environmental factors that can definitely disturb sleep. And so that could be things like light pollution, if you will, or excess light in the environment where a person is trying to sleep, or excess noise. Either you live near the railroad track, or you live near a busy highway, or you work a night shift and they're building a new building right next door to you. As well, people often can get into bad habits, and one of the one of the things that we're going to talk about a little later in this presentation is, how to relearn some good sleep behaviors or sleep hygiene. So when it's an environmental factor, though, that's really what you want to address. So, you know, most people can't just move because they're doing construction next door. Or there's a railroad track not too far away. So then what you want to do is help people compensate. So that could either be a little white noise machine, or, you know, that creates some white noise in the background, or wearing a mask that you can buy at the local pharmacy, a sleep mask. But really an analysis of what is the environment that a person has for their sleep is very important. And then, of course, there are the people who have all sorts of combinations of these diseases and challenges. So here's what I am going to propose for helping with sleep problems. And I'm going to spend some time going over sleep hygiene, what it is, and how to educate patients on this. There are entire cognitive behavioral therapies that are structured around teaching people how to change their sleep habits and improve them. Exercise is really key, and that's sort of one of the biggest challenges with older adults is that many of them have cardiac or pulmonary or arthritis, joint issues that impact their ability to get exercise. But for those of us who are able to exercise, it is quite key. And even as much as 20 to 30 minutes a day of walking, you know, and you can do it in chunks, in 5 or 10 minute chunks, and you can work up to it. Anything we can do to help people be physically active. I mean, we're not talking about you need to go to the gym and run on a treadmill. You can actually incorporate physical activity in your day. And for many older adults, it doesn't take more than 20 to 30 minutes of walking a day to give them significant benefits in sleeping better. And so it's a great time to use some motivational interviewing techniques, like so somebody is motivated to sleep better. And so really getting them to track activity with how well they slept the night before. And what I have often done is given people kind of a blank calendar with, you know, 1 to 31 for days of the month, and you just, you know, use one for every month, and you record how many minutes of activity a day you do, as well as how many hours of sleep, and then whether you felt rested when you woke up. I use a similar calendar for people who have major depressive disorder, and I have them also on the same calendar, ask them to track their mood. You can modify that a little bit for people who live in a facility sometimes if they have engaged staff who you can work with, or for people who are living at home if they have a involved spouse or significant other or family member who's living with them who can help with that. And then treating sleep diseases, again, as I mentioned, you know, REM behavior disorder and other sleep problems, which are usually diagnosed, and the initial treatment is started by the pulmonologist at the sleep lab. And finally, it's really important to treat psychiatric diseases such as major depressive disorder and post-traumatic stress disorder. And there are some kind of interesting medications that things to know about that. So most antidepressants negatively impact sleep architecture, as well as major depressive disorder itself negatively impacts sleep architecture. Post-traumatic stress disorder likewise, and there is a fair amount of evidence that if you work on the sympathetic nervous system, you can help people with PTSD and major depressive disorder or other anxiety or mood disorders regulate their sleep. And so, for instance, prazosin, which is a very old blood pressure medicine, it works on the sympathetic nervous system, the fight or flight part of your nervous system. And so that is one treatment that can be used to decrease the fight part of fight or flight, and that will help normalize sleep architecture in people with major depressive disorder, PTSD. There is some evidence that possibly even in people with dementia, prazosin can do that, although it's not all that robust. And all of those uses are what we call off-label. So there's evidence for them, but there's no disease. And then I'm getting a couple questions. Nirmala, I have read that sleep disturbance is a prodromal symptom for depression, and can you comment on the bidirectional relationship with sleep and depression? That's a great question. So what I would say is that depression is a mood. So depression, the mood, isn't actually related to sleep per se. Grief can cause sleep challenges, severe grief, or even moderate grief. But major depressive disorder, the illness, a key part of it for most people is sleep disturbance. And so for major depressive disorder in particular, what we tend to see is either early morning awakening, which is where someone wakes up at like 2 o'clock in the morning or 3 o'clock in the morning and cannot get back to sleep for many hours, if at all. They wake up and they are like wide awake, not rested, but wide awake. And then what we call mid-cycle awakening, which is where they frequently wake up during the night and don't actually complete a full stage 1, 2, 3, 4 REM, 1, 2, 3, 4 REM. They don't go through that normal cycle of sleep. So major depressive disorder often involves neurovegetative symptoms, of which sleep are the most common. And one of the key things to know about sleep disturbances in people who have major depressive episodes is that is actually a predictor of response to treatment with antidepressants. So those people who have a major depressive episode and have mid-cycle awakening or early morning awakening, that group of people is more likely to benefit from an antidepressant than all comers with major depressive episodes. And then as far as bidirectional relationship, so some people who have major depressive disorder, their illness script, their disease process, when they have recurrent episodes, what they find is they develop symptoms in a very predictable pattern. And so some people, a significant number of people actually with major depressive disorder will have sleep disturbance as the first symptom, followed by other symptoms until they actually qualify for the full syndrome of major depressive disorder, which requires a number of different symptoms to actually have major depressive episode. And here's a question: outside of prazosin, are there other ways to address and improve sympathetic nervous system? Yes, there are. Exercise, for one, regular exercise is extremely helpful in regulating your sympathetic nervous system. There are some therapeutic techniques, some cognitive behavioral techniques that we use with anxiety disorders, for instance, panic disorder. And so exposure to things that make you anxious is a way to actually rewire your sympathetic nervous system. And so that's sort of a whole talk by itself. As far as that is also one of the ways that beta blockers probably help with anxiety. They don't treat the anxiety disorder itself, but they treat the sympathetic nervous system dysregulation, sort of the fight or flight gone awry. Okay, hopefully that answered some of those questions. Keep them coming in. So I'm going to talk about sleep hygiene, and I'm going to sort of talk about what it is, and I'm also going to talk about how I talk to patients. And I'm going to spend a decent amount of time doing that. And why, you say? Why are you spending all that time when you could be telling us about medications? Well, because this is more effective and more long-lasting and more life-changing than medications for helping with sleep. It's harder. It takes more time. It's time intensive. So getting somebody in, if you're in an outpatient primary care office, having somebody on your staff who becomes an expert in working with people on sleep hygiene is a great use. If for instance, if you have a primary care medical home, that's a great use of staff time. Otherwise, being familiar, there are many different websites that go over this and have handouts and education around this. But this is by far the most important thing that we can do for people who are having sleep problems. Help them have better sleep hygiene. And so there's a couple different things. One is you want people's brains, because sleep is controlled by our brain. So you want to train the brain so that it knows when to go to sleep and when to wake up. Now, maintaining usual bedtime is important, although it's actually even more important to maintain the usual waking time. And so, but you want your brain to know, this is the time I usually go to sleep. You want your brain to know, this is the time I usually wake up. And you can tell when you're starting to be effective on that, because what will happen, let's say you go to sleep every night at around 11-ish and you get up every morning, your alarm goes off at 6:30. You will know that you have good sleep hygiene when you wake up a couple minutes before the alarm goes off. That actually is great evidence that your brain has been trained. And that's the key thing that we're trying to do with sleep hygiene. We are trying to train your brain. And of course, our brains are extremely powerful. There is no sensation, thought, or feeling that you can have, without your brain. And so the best way to handle this is to focus on sleep routine. So besides the usual bedtime and usual waking time, which means 7 days a week, so that's sleeping in on the weekend, it's better than no sleep at all, but it is not good for the brain for you to sleep in on weekends. It's much better if you can adjust your sleep schedule during the week to go to bed earlier so you don't need to sleep in on the weekends. You want to prepare for sleep starting 2 to 3 hours before bedtime. You want to make sure that you have daytime activity, that you are using your major muscles groups during the day, and the earlier in the day the better. and you want to stop doing any sort of exercise or robust, moderate walking 2 to 3 hours before your planned bedtime. So, and you want to avoid naps when you can. Naps are the enemy of good sleep at night. And if somebody absolutely has to nap, they should set an alarm for 10 to 15 minutes and then get up. You want to promote social interaction. It turns out that those of us who interact with others up until a couple hours before bedtime actually sleep better. So it's part of training the brain to be active during the day and when the conscious brain is in charge, as well as then getting the brain ready to relax and change gears as you get ready for bed. And then you want a bedtime routine. It's actually the old milk and crackers or a glass of warm milk or whatever it is. There actually is good evidence for that. And it is all part of the training of the brain. So some people will read or listen to some music as part of their bedtime routine. Often, people will brush their teeth, right before they go to bed, or have, particular activities that they do. Right before you go to bed is a great time to encourage prayer for those people who pray, or meditation for people who are interested and motivated in doing that. But you can even kind of encourage that in just a moment of contemplation. And so one of the things that has been shown to be most associated with healthy aging is regular gratitude. And so some people do that first thing in the morning, and some people do that at night, right before they go to bed. And so a sort of the practice of listing out 3 or more things that you are grateful for, that you are truly feel grateful for, will impact your ability to be optimistic, your ability to be emotionally resilient, and it will impact your ability to sleep well, as surprising as that may sound. So I'm getting a couple questions. Does a glass of warm milk really help? If so, how? And then can you comment on narcolepsy? So warm milk, if you warm your milk, it releases some chemicals that make people a little bit sleepy. I'm not so sure that actually it is enough of a change that would make most people sleepy, but it does. The thing about a glass of milk is that has a little bit of protein in it, and it's not going to fill, it's not like a big meal, but it will decrease hunger. And so, for instance, I'm not really reviewing it here, but one of the things that really severely interferes with the ability to sleep are people who are hungry, because it's very hard if you're hungry to think about anything else. So people who are hungry don't sleep well, they don't learn well, etc. Can you comment on narcolepsy? So narcolepsy is a particular sleep disorder, and there are particular treatments for it. I'm not exactly sure what other comments. So narcolepsy is where people sort of unexpectedly have where they just fall asleep while they're in the middle of a sentence, or in the middle of doing something, or in the middle of their day. It's actually not all that common, but it's not subtle. So if you do have that, you definitely should seek treatment. Do I have any sleep hygiene suggestions that help for elders with sundowners? I do, and this next slide, I'm going to point out some of those that do. So that's a great prep right for where we are. Minimize and avoid foods that disturb sleep, which would be lots and lots of food, for instance, so a big meal. As well, you want to avoid stimulants and in the afternoon or evening. So the old, I can't drink coffee anymore at night kind of thing, or caffeinated tea. You want to create an environment for sleep. So you want to work on the noise. You want to set the room temperature to patient preference. A little bit cooler room is actually better for sleeping than a warmer room for most people. And for older adults, both a warmed blanket and a weighted blanket have been shown to help people who have dementia sleep better. As well, early morning light. And I'm not sure if that's on the next slide or not, but so, you know, they have full spectrum lights that we use to treat seasonal affective disorder, or people who get major depressive episodes when the days are shorter. We often will prescribe 15 to 20 minutes of exposure to full spectrum light early in the morning, and that helps reset the circadian rhythm clock in your brain. And it turns out that exposure to full spectrum light for people with dementia in the morning is very important. One of the other things that's important for sundowners, when that is referring to somebody who has dementia and gets agitated in the afternoon, is making sure that people with dementia are getting some rest. And actually the old 20 minutes to 30 minutes of laying down after lunch is a very useful habit for people with dementia. So like on the best dementia unit, you would have bright lights and activities in the morning, and you would do your best to get everybody up and dressed and fed and active. There would be morning exercise, incorporating some fresh air if possible. Then after lunch, there would be you know, a period of time where the lights are kind of turned down and it's a quiet environment, and you try and minimize noise and encourage people to rest for up to 20 to 30 minutes. And then sort of later in the afternoon, get people up and engaged in an activity such as music or some very light walking. You know, that would be actually a great way to help prevent and minimize what people refer to as sundowners, much of which seems to be related to fatigue and people with dementia not being able to rest appropriately. And then the warmed blanket or a weighted blanket often helps people, and there's sort of a whole science to how heavy of a blanket to use. And I might be able to find some resources and information on that that they could send out. Nightlight, if people are getting up in the middle of the night, you do want to make sure that there is a nightlight somewhere where they can you know, near the walkway if they're going to be walking to the bathroom, for instance. And this is one of those reasons why sometimes a bedside commode might be better for some people, and that it's kind of a judgment call of when you would want to do that. But that can decrease fall risk for people who are getting up at night. And the white noise, especially in facilities or hospitals. You want to elevate the head of bed as required. People have very distinct preferences around pillows. You want to make sure that pain medications are administered, and this cannot be overemphasized enough for people with osteoarthritis or significant pain. that is always going to interfere with sleep. Massage of people's back or feet can promote relaxation. And so, I know a number of people who actually incorporate a little brief 5-minute warm water or warm water with Epsom salts foot bath for 5 or 10 minutes as part of their bedtime ritual. That is a great way to help promote relaxation. Warm or cool compresses to painful areas as indicated, although you have to be, if people have cognitive impairment or people are unable to move themselves, turn themselves, you have to be very careful about things like heating pads, for instance. That is, those can cause severe injury when not used correctly. So you need the right audience for that. But for people who don't have cognitive impairment, warm and cool compresses to painful areas as indicated. Progressive relaxation or guided imagery, so there are some tapes that you can get, or see, I'm giving away my age, but you could stream some relaxation practices. You could stream guided imagery, for instance. Amazingly, encouraging people to go to the bathroom before going to bed actually is good. That will help people get to sleep and stay asleep. Keep the bathroom path clear, provide a bedside commode. And any online CBT sites that you would recommend? There are some good online sites. I actually almost always start at the National Institute for Health. NIH has a great website, and they actually have, and they have all these institutes: National Institute of Mental Health, National Institute on Aging, National Institute on Neurological Diseases. Those would be the three that probably would have things around sleep. And they have lots of resources. They have patient education that can be handed out. Any citizen in the country can can submit a request, and they will send you DVDs and pamphlets and education material on topics. And they do have some references to CBT sites, and that's where I would start. The other places that I go are actually either university sites or other countries that have robust healthcare systems, such as Canada or the United Kingdom or the European Union. So those are actually, I try and start from those sites that I know have already, they have some vetting, and they're not just going to have anything referenced on their website. So I use that as sort of a shorthand so that I myself don't have to vet every website that I see. What are my thoughts on the use of melatonin? Great question. And so our last slide here is about the risks and benefits of pharmacology for insomnia. And I see I didn't put melatonin on the slide here. I actually think melatonin is a reasonable and safe thing to try. It's the evidence is not clear that melatonin actually goes through the blood-brain barrier for those of us who have a healthy blood-brain barrier. So it's not totally clear to me what exactly melatonin is doing for those people. However, we do know that the use of 1 milligram or 1.5 milligrams of melatonin at bedtime decreases the incidence of delirium in people who are 65 and older who are admitted to a hospital. I think the side effects or risks of melatonin are very, very small. So I think it might have some benefit. I know people who swear by it. I myself have used it from time to time. I don't think there's super robust evidence, but I think the risks of it are very small. And it's much safer than any of the other things that I'm going to talk about right now, which are benzodiazepines and near benzodiazepines like Z drugs. So there's a whole set of them out there. Zolpidem, for instance. Benzodiazepines are medicines like Valium or lorazepam, Ativan, diazepam, temazepam. There's probably 8 of them. So they almost all end in PAM. And so those are medications that are often FDA approved for sleep, but they're only FDA approved for a very short term, so a week, 2 weeks at the most. And what happens is people who have chronic sleep problems, they might get some benefit when they first start using them. But when we look at trials, long-term trials, what you see is people might get to sleep 2 to 5 minutes earlier, and they might sleep 6 to 8 minutes longer overall if they have one of those medications, once they are taking them regularly, night after night. And that is not what they're FDA approved for. So that is an off-label use of them. And what we do know is they're associated with falls, they're associated with problems with attention, they're associated with cognitive impairment, they're associated with delirium. They're when in combination with alcohol, they can be fatal. And in combination with opiates, they can be fatal. So benzodiazepines are often thought of by healthcare professionals as relatively innocuous treatments, but I think they should be really regarded as necessary evils in certain instances, like alcohol withdrawal is a great reason to use a benzodiazepine. Bipolar disorder might be a reason to use a benzodiazepine, but now I'm really hard pressed to come up with another great reason to use a benzodiazepine. So I think they're very overused and they have very many risks to older adults. Lots of other drugs are commonly used for sedation and to help people with sleep. So antidepressants, we used to use amitriptyline all the time. And then amitriptyline got put on the Beers list, the very first Beers list there ever was. And so people have been avoiding it ever since. It makes people sleepy. Allergy medicines like Benadryl or diphenhydramine also make people sleepy. Antipsychotics like Seroquel or quetiapine make people sleepy. Opiates make people sleepy. I think you have to be very careful if you're using those drugs to help somebody sleep. If you're using those drugs to treat an underlying depression or anxiety or pain disorder or psychotic disease, then that's one thing. But if you are using those agents solely for sleep, there is very minimal evidence that they help over the long term, and there is lots of evidence of significant risks, both to cognition and to around falls. And so I think it's the easiest thing for us to do is to say, take some, the over-the-counter sleep aids like Sominex. Those mostly contain diphenhydramine, and diphenhydramine is an allergy medicine that is anticholinergic and antihistaminic. It's actually, in some murder mysteries, they use that. You can make somebody look like they have dementia by giving them diphenhydramine twice a day, every day. These are very powerful medications, and I think we really should re-look at using them for sleep unless you're actually really honestly treating an underlying illness. And then stopping medications that are anti-sedating. So medications that are keeping you awake, like stimulants and dopaminergic medications. How about chronic snoring? So that is actually what you want to do is look to see if somebody has sleep apnea or other sleep disturbance. So somebody who has chronic snoring is a great person to refer to a sleep lab. And they will there recommend some treatments. And RBD is REM behavior disorder. And that is when you are, those are people who act out when they're in REM sleep. So when you're in REM sleep, your skeletal muscles, your arms and your legs are supposed to be paralyzed if you have normal REM sleep. And so you're not supposed to, you're dreaming that you're doing things, but you're not actually doing them. And REM behavior disorder is where that paralysis, that muscle paralysis doesn't happen. And so people act out. CRD is circadian rhythm disorders. And so that's when you have sleep cycle disturbances, and those are most often diagnosed when people go to a sleep lab. And I apologize for the abbreviations. I did actually update that on a slide, but obviously I didn't quite get that to the final product. And I think I am running out of time because it is 12:58.
Why don't you answer one more question?
Okay. The dangers of using sleep aids. I'm thinking about older adults. And yes, that is what I tried to address when I was talking about sedating medications. And so over-the-counter sleep medications almost always are anticholinergic and antihistaminic. So they cause dry mouth, and they cause impaired attention and impaired ability to think and problem solve. They're associated with automobile accidents the following day, as well as poor performance in tests and other things. So sleep aids, that's why I spent so much time talking about the really important things. Exposure to bright light in the morning, exposure to walking 30 minutes a day, which can be done in 5 or 10-minute chunks at a time. Paying attention to when you wake up as well as when you go to sleep, and setting the stage, having a routine for sleep.
Awesome. Thank you, Dr. Nash. We appreciate your time as always. Thank you everyone for participating today. The link is up on the screen for the survey that will let you get CME if you're after that. You do need a passing score, and that test closes at 9 a.m. next Tuesday morning. A reminder to our site host to please send in the sign-in sheets and the CME disclosure and accreditation statements by that same time as well. And we hope to see you all in January for treating agitation in dementia, practical insights and management techniques. Thank you everyone, and have a wonderful Friday.